Okay, good. So we'll be looking at the hyperprolactinemia. So when you talk about hyperprolactinemia, what we mean is that you have a lot of prolactin in your blood. Okay. Now, before I even come to the causes, let's look at the clinical features. Okay. Now, the clinical features, if you remember, I said that the prolactin inhibits luteinizing hormone and then follicle stimulating hormone. So most of the complaints are going to be with infertility. Okay. So someone has menstrual problems. Okay. Someone has menstrual infertility, amenorrhea, oligomenorrhea. Okay. And then anovulation. Anovulation means that they cannot ovulate, and because of this anovulation, okay, that causes the infertility. Loss of libido. Of course, estrogen gives libido. Okay. And then intercourse may be painful for obvious reasons. Okay. And then there is osteoporosis and then fracture. Now, if you have read the slides on metabolic disease of the bone, okay, we said that estrogen has bone protective effects. So any conditions that lead to low estrogen levels, okay, like menopause, okay, like prolactinemia, okay, they can all cause osteoporosis and bone fracture. Okay, good. Aside that, because of the increased prolactin levels, okay, the woman will be producing breast milk when she's not pregnant. So we call that galactorrhea. So these clinical features suggest that someone has prolactinemia. Okay, now this is in females. In males too, the same thing. It has to do with fertility issues. So impotence, diminished libido, oligospermia. From the functions, if you know the functions, the functions of testosterone in males give them libido. If you have prolactinemia, LH is inhibited. You can't produce enough testosterone. You have diminished libido. Follicle stimulating hormone is also inhibited. So spermatogenesis is not complete. So you have oligospermia. Okay, and all these. The headaches and the visual disturbances are as a result of the tumor in the anterior pituitary gland, okay, which is causing compression of the optic chiasm. Okay. So now the question is, what can cause prolactinemia? So first of all, the commonest cause of prolactinemia is not the tumors. Okay, the commonest cause of the prolactinemia are actually drugs that we give to patients. Okay, now some of the drugs, remember I said that prolactin is under dopamine inhibition. So if I give any drug that can fight against dopamine, then prolactin will be produced, okay, in excess. So dopamine antagonist drugs can cause prolactinemia. Okay, so the cause of prolactinemia, one, dopamine receptor blocker. Okay, like haloperidol, which is used in patients with psychotic conditions. Okay, haloperidol. And then there are some drugs which are used to treat hypertension. Okay, if you remember the central agents for hypertension management, we have, if you remember this, methyldopamine receptor. This one, I was the one who taught, I gave a tutorial on this one in your class. I came to draw it on the board. I remember it very well. Alpha methyl-dopa, and I explained, I even drew how dopamine is formed. Okay, and if you remember, from tyrosine we get dopa, then from dopa we have dopamine. But if you give someone methyl-dopa, okay, methyl-dopa, alpha methyl-dopa is going to inhibit the dopa, okay, so that you don't produce dopamine. And if you don't produce dopamine, dopamine cannot inhibit the prolactin. So you have a lot of prolactin in the system. And some other drugs like estrogen therapy and then narcotics. Okay, so these are drugs, pharmacological agents. Let me see. Good. Now let's go to the pathological ones. So the pathological ones are actually tumors. So if you have tumors anywhere producing prolactin, then um, we call those tumors prolactinomas. Okay, so they can cause this one. Good. Now the second thing, so this one is pituitary disorders. That's the pathological. We have pituitary disorders, and you have some other conditions which has nothing to do with the pituitary gland. Okay, but it's causing hyperprolactinemia. The first one is hypothyroidism. And at the beginning of the lecture, I mentioned 4 times that thyrotropin releasing hormone, okay, thyrotropin releasing hormone also cause release of prolactin. If you remember that, and I mentioned it 4 times that thyrotropin releasing hormone. At the first session we had, thyrotropin releasing hormone will cause the release of prolactin. So if I have hypothyroidism, okay, if I have hypothyroidism, what's going to happen is that the hypothyroidism is going to send a negative feedback to the hypothalamus. So the hypothalamus is going to produce a lot of um, thyrotropin releasing hormone. Okay, because the person is hypothyroid. Okay, so the body wants to produce a lot of thyroid hormone. So what the body is going to do is that it's going to cause um, the hypothalamus to produce a lot of thyrotropin releasing hormone, and that can also cause the prolactin to be released. So sometimes someone with hypothyroidism will come with hyperprolactinemia, and you should be able to explain why. Good. And sometimes too, there's what is called ectopic secretion. So you have something, a tumor somewhere, not in the pituitary, somewhere also producing prolactin. Okay. Next one is patient with chronic renal failure. What happens is that the kidneys are responsible for excreting the prolactin. So if your kidneys are not functioning well, then prolactin will accumulate in your system and you have high prolactin levels. Good. So what do we do? So the first thing we said is that first measure the prolactin levels. Okay. If you do and then the prolactin levels are high, you perform thyroid function test. Why do you perform thyroid function test? I have explained to you that hypothyroidism can be the cause of the high prolactinemia. So that in this case, what you have to do is treat the hypothyroidism, and then the prolactin levels will come back to normal. Okay, good. Then what you do is, when you see that, okay, it's not from the thyroid, okay, but it's actually maybe a tumor somewhere, then you do the MRI to find the pituitary. Because you see, difference between MRI and then CT scan. Okay, MRI is very good in identifying soft tissues. CT scan is for bones and other hard tissues. Okay, what is the treatment? There are 2 ways. Okay, if the prolactin, if the tumor is not that large, okay, and it's not causing visual effects or headaches, what you can do, you can give drugs. Okay, drugs that are going to act like dopamine. So we call those ones dopamine agonist. The example is what is called bromocriptine. So when you give bromocriptine, it's going to function like dopamine and inhibits the cells from producing prolactin. Okay. So if you hear any drug that ends with cryptin, you can use it. So bromocriptine. Okay. Then if it's large, then you do surgery and you remove the tumor. Good. Now we are almost done with this part. Hypo, what is this? Hypopituitarism. Okay. This is a condition in which the pituitary glands are producing uh, um, less of their hormones. Okay. When we use the term pan-hypopituitarism, that means that both anterior and posterior lobes are affected. So this one, depending on which cells are affected, then we can have the conditions. If the growth hormones are not being produced, I mean, you can tell what will cause. Okay. Now, what's going to cause all these things? The panhypopituitarism. Okay, anything can cause it. If you have infections of the brain, sometimes you could have tuberculosis in the brain, okay, abscess or syphilis in the brain. It can affect the pituitary gland, and it will destroy it and lead to loss of function. Vascular disease, if you have how do you call it, infection, sometimes the tumor, okay, sometimes there could be a tumor of the pituitary gland, and as the tumor grows, it's outweighs its blood supply, okay, then the gland will start dying, okay. There's a condition we call the Sheehan's disease, which is what's called postpartum necrosis. So sometimes after birth, you notice that the woman will lose a lot of blood, okay, either we call it postpartum hemorrhage, okay. They are losing a lot of blood after giving birth, and that will cause shock, okay. And because of the shock, not enough blood gets to the pituitary gland and it starts dying, okay. Good. Other things like head trauma, radiations to the head, surgery. Of course, if you do surgery for any of the tumors, remember that you are removing the pituitary gland, so you are not going to get the pituitary gland hormones. Good. So if someone has growth hormone deficiency, okay, I'm sure this part you can read them. We have what is called the recombinant human growth hormone therapy. You can give it to them. Okay, I'm not going to talk about this. The posterior lobe. I've talked about the syndrome of inappropriate ADH release in the water regulation. Okay, and we notice what can cause inappropriate ADH release. Okay, we said that it could be tumors. If you remember, we said it could be tumors, and we said it could be infection. I mentioned pneumonia and encephalitis, and any tumors of the head. Okay, all these things can cause ADH to be released inappropriately. Okay, and we looked at some of the causes. Okay, I'm not going to go into that. Okay, and I also mentioned diabetes insipidus. Okay, and all these things can cause it. Tumor can cause it. Infections, trauma, surgery. Okay, good. Let me see. So we have some few slides to go. Okay, we have about some 6 slides more to go. So now, some of the biochemical tests for the pituitary function. Okay, so we could have, there are 5 categories, okay, of tests that you could do. So the first one is that you can just measure the hormone level. So you can straight away measure, let's say, the prolactin levels in the blood. Okay, so we could just do that. Or we can measure, let's assume we are dealing with someone with let's say hyperthyroidism. Okay, what we can do is that we can measure the TSH levels. Okay, that is the hormone produced by the anterior pituitary gland, and then we can also measure the hormone produced by the gland it is affecting. So we know TSH will affect or will cause the thyroid glands to produce the thyroid hormones. Okay, so what we can do is that we can measure the TSH levels, and we can also measure the thyroxine levels. So per measurement of the pituitary plus the N organ hormone. So this is something that we can do. So the first thing we can do is we can just measure the hormone level. The second thing we can do is that we can measure the hormone okay, that the organ is producing, as well as the hormone that the pituitary gland is producing. Good. The third thing we can do is what is called the dynamic test. Okay, so for that one, what we do is um, the suppression. Okay, this is where we do the suppression test. Okay, where we give a certain drug which is supposed to suppress the pituitary gland, so that if it is not able to suppress it, then we know that okay, this one is overproducing. Okay, so remember we talked about the OGTT test. Okay, not only that, when we go to the adrenal glands, we also see that we also do some other suppression test. Okay, then we have what is called the combined dynamic test. Okay, then you have some other tests that you can also do. Good. So prolactin, as I've already mentioned, you just measure the prolactin levels. Okay, so this one you just measure it raw like that. You don't need to do any stimulation test or suppression test. So the fact is that if you have the prolactin 5 times or more than the upper limit, then you can say that no, this one there's a tumor somewhere. Okay, good. I'm not going into detail. Then for the paired measurements, okay, usually the thyroid gland. Now here you have to understand it very well. Okay, we could have, now we'll be using terms like primary and secondary. Okay, when you use the term primary, so for example, if I say primary hyperthyroidism, okay, that means that the organ that is producing that hormone is defective. Okay, so in this case, if I say primary hyperthyroidism, that means that the thyroid gland itself is what is producing the thyroxine hormone. So this one, you see, we know that thyroid stimulating hormone must cause the thyroid gland to produce a thyroxine hormone. But here's a case where we have a certain pathology of the thyroid gland itself, okay, which is causing the thyroid gland itself to produce a lot of thyroxine hormone. This time, it's not TSH. The pathology is with the gland itself. So what's going to happen is that the excess thyroxine hormone will go to the hypothalamus and cause a negative feedback effect. And then it will also cause the TSH to also be reduced. So in this case, we are seeing anytime you measure the TSH level and the thyroxine hormone, and you see that the thyroxine hormone is high, but the TSH level is low, then we are talking about a primary hyperthyroidism. That means that this case, don't go and look in the brain, go straight to the thyroid gland, because there either could be a tumor of the thyroid gland, which is producing a lot of thyroxine hormone, and that thyroxine hormone is giving a negative feedback, reducing the TRH levels as well as the TSH levels. Okay, so that's over here. If when you talk about primary hyperthyroidism, what is happening is that the TSH levels are low, but the T4, which is the thyroxine hormones, are high. Examples of conditions that can cause this are tumors of the tumors of the thyroid gland. Okay, good. Now, so I've talked about the primary hyperthyroidism. Then we have secondary hyperthyroidism. So for secondary hyperthyroidism, the problem is with the pituitary gland itself. So this time the pituitary gland is producing a lot of TSH, and that TSH is causing the thyroid hormone to produce a lot of thyroxine hormone. So this time when you do the paired test, you see that the TSH levels are high. Then the T4 levels are also high. So in this case, okay, so usually it's elevated. So you see that the TSH levels are elevated. The T4 levels are elevated, but the TSH levels too can be a bit normal, okay? But if you forget that it's normal, remember that it's going to be elevated, and T4 is also going to be elevated. Good. Let's go to the hypothyroidism. Hypothyroidism, we could have primary and secondary. If you say primary hypothyroidism, the problem is with the thyroid gland. The thyroid gland is not producing enough thyroxine hormone. Therefore, it's going to give a feedback to the hypothalamus to produce a lot of TRH, and the TRH will cause the anterior pituitary to produce a lot of TSH. So this is a case where you see low levels of thyroxine hormones and high levels of TSH. This should tell you that this patient has a primary hypothyroidism. So if you see primary hypothyroidism, that's an end organ failure. You see that the T4, which is the thyroxine hormones, are low, but the TSH levels are high. Similarly, when you talk about secondary hypothyroidism, that means that the TSH levels are low, and hence the how do you call it? The thyroxine hormones are also very low. So secondary hypothyroidism, everything is low. Good. Then let's look at for the follicle stimulating hormones too. Okay. For the ACTH, I'll come back to this when we do the adrenal hormones. Okay. No, even this one, I'll come back to this slide when you do the adrenal hormones. Good. For growth hormone deficiencies, I have talked about it. Just measure the growth hormone levels. Okay. Good. And the second thing you do is that if you see that this person has a growth hormone deficiency, then stimulate, try and do what is called a stimulation test to see whether the pituitary gland can really produce the hormone. Okay, so there's what do we use to stimulate? Okay, we can use glucagon to stimulate. Okay, if you use glucagon, if you inject the patient with glucagon, okay, the glucagon should be able to stimulate the growth hormone. If the glucagon is not able to do it, okay, then there will be a low level of growth hormone. Then we can say that no, this one, there's growth hormone deficiency. Growth hormone excess, as I said, you do the suppression test, and we talked about the OGTT test. Okay. Okay, and I have mentioned this. Insulin can cause hypoglycemia. Insulin can cause hypoglycemia. So if you have any tumor producing insulin, okay, there's a tumor we call insulinoma. Okay, it produces a lot of insulin. Then remember that the blood glucose levels will fall very low because of the increased insulin levels. Okay, I think I will end here. There are some questions here, but we will not attempt to look at them. Okay, good. So go over everything you've done so far.